We will go about the figure 37.4. The myocardial tissue is seamed out. The depth of the seaming is gauged with the thumb and index finger. Superiorly, the aortic homograph is transected 5 mm above the tip of the commissures. And then the aortic sinuses are removed, making U-shaped incisions and leaving a rim of 3 or 4 mm of aortic valve for the attachment of the homograph to the aorta. For the orientation of the homograph, it is easy to remember that the right cusp is sitting entirely on muscle. Conventionally, the homograph is rotated 120 degrees counterclockwise so as to bring the homograph's right coronary sinus against the recipient's left coronary sinus. The advantage of the rotation is that the muscular rim of the homograph posteriorly overlies the fibrous tissue of the anterior leaflet of the mitral valve, while the fibrous portion of the homograph lies anteriorly and to the right across the ventricular septum of the recipient. The original right cusp becomes the new left cusp. This avoids sewing muscle to muscle anteriorly and results in a more secure suture line that does not bulk posteriorly. The first of the 3 guarding state sutures is now placed immediately beneath the nadir of the remnant of the left cusp and beneath the right cusp of the homograph. The other 2 sutures are similarly placed beneath the nadir of the other 2 cusps. The figure is 37.5. Here is the figure of 37.5. Here are 3 stitches and the valve is placed in the annulus in the 37.6, and then with the needles it is going to swing in around, and we are going to read our topic. The homograph is then lowered into the left ventricular outflow tract and the valve is turned inside out and inverted so that the lower edge of the homograph is exposed. The 3 stage sutures are tied down and the proximal suture line is begun in a continuous over and over technique. This suture line does not follow the scallops of the recipient annulus but proceeds in a horizontal line beneath the commissures. The only exception to this is in the region of the membranous septum, where the suture line should be through or just below the annulus to avoid injury to the conduction system. The homograph valve is then pulled back into the aorta, throwing the pillars up into the aortic root. A mattress suture of 4-0 Prolen is placed through the top of each pillar and through the recipient aortic wall about 5 mm above the normal location of the commissures. The ends of each commissural mattress suture are tagged and not tied to facilitate the manipulation of the graft away from the recipient aortic wall when placing the upper suture line. The position of the pillars must be judged carefully in both the vertical and the horizontal planes, particularly the 2 pillars on each side of the aortotomy incision. The distance between these pillars should be a little greater than the distance between the other pillars to allow for the aortotomy closure. The distal suture line is then carried out starting at the bottom of the left sinus. The suture line is in a subcoronary position and takes the host's aortic wall and the upper margin of the homograph. The running over and over sutures proceeded along each half of the left sinus. Each of the sutures is tied to the commissural mattress stitch. The suturing along the right and non-coronary sinus proceeds in a similar fashion. Now we are going to figure 37.8 and 9. Here are the figure of 37.8, and you see that the valve has inside view, how it's sewn in aortic wall, and 37.9 the sewing is with pledged sutures has completed. Now we are going to our text. The autotomy incision is closed with a simple over and over stitch of 4-0 polypropylene suture, placing a pledged mattress suture at each extremity of the incision. In his classic description of the freehand subcoronary homograph insertion, Ross retained the aortic wall of the non-coronary sinus and didn't rotate the homograph into the left ventricular outflow tract of the recipient. By retaining the non-coronary sinus, one reduces the risk of malalignment of the three pillars and maintains the cylindrical configuration, which is so important to avoid valvular regurgitation. Retaining the aortic wall of the sinus, which will occupy the host non-coronary sinus, doesn't preclude insertion of the homograph for the proximal suture line. The closure of the aortotomy incision incorporates the wall of the homograph to obliterate the space behind the non-coronary sinus. In children with small aortic roots, the authors prefer not to invert the homograph while performing the proximal suture line and to use simple interrupted sutures 4-0 Ticron, holding the homograph out of the aortic root to facilitate the exposure. This is indeed the technique that was recommended by Ross even for large aortic roots. A homograph with an internal diameter of 60 mm can be inserted into a 19 mm root without a hemodynamically significant gradient. However, in pediatric practice, the aortic annulus is often smaller or the disease is not limited to the aortic valve itself, but to the entirety of the left ventricular outflow tract. In these patients, the techniques of enlargement of the aortic root have to be considered. Prosthetic aortic valve replacement. Following excision of the native valve, the annulus is sized. The sizer should sit in the annulus, not on the annulus. I will repeat it. The sizer should sit in the annulus, not on the annulus. Trying to force in a valve that is too large can cause disaster, such as coronary ostial impingement or tear of the annulus. We have now completely abandoned bioprostheses in the young age group because of their early degeneration. We have used a number of low-profile mechanical prostheses. The most commonly used is the centrifugal valve and more recently the carbomedics valve for the small annulus. If too small, the aortic root may have to be enlarged. See aortic root enlargement section. The prosthesis is inserted with either simple interrupted or mattress suture. They are first placed in the area of the left coronary sinus, starting at the commissure between the right and the left sinus, then in the right coronary sinus, and finally in the non-coronary sinus. The sutures are placed through the remnant of the annulus. Care must be taken to avoid deep suturing in the area of the membranous septum beneath the junction between the non-coronary sinus and right coronary cusps to prevent injury to the conduction system. The sutures are placed through both annulus and prosthesis as the replacement proceeds. Now we will go to the figure 37.11 and 37.12. Here are the figures of 37.11 and 37.12. When all the sutures are placed, the valve is lowered into the position and the sutures are tied. If mattress sutures are used, this may or may not be reinforced with Teflon pledgets. In children, because of the fragrant small size of the annulus, the mattress sutures are placed from below the annulus and up through the prosthesis to place the annulus between the sutures and the prosthetic device using the maximum diameter of the aortic root. Aortic root replacement. And this topic we will continue in the next part. Thank you very much.